Hello friends, today we are going to discuss about transfusion related lung injury. So transfusion related lung injury is defined as new acute lung injury which develops within the 6 hours of transfusion of one or more unit not attributed to another and acute lung injury risk. So pathophysiology of the trali is not fully understood at present. In the 1950s, the initial reports were made on the role of anti-leukocyte antibody in the pathogenesis of trali when it was administered to the test subject. 50 ml of the blood from the patient contained in the containing leukoagglutinates. The clinical manifestation following this administration included hypotension, fever, respiratory failure, and bilateral pulmonary infiltrate on the chest, and radiography with full recovery within the 3 days. There are two mechanisms which lead to the development of syndrome, that is immune mediated and no immune mediated trial. Immune-mediated TRALI is caused by anti-HLA antibody class 1, 2, and the less frequent antibodies directed against specific antigen of the granulocyte, that is human neutrophil antigen, which can be present in the serum of the recipient or donor and react with the donors and the recipient's leukocyte respectively. The immune-mediated TRALI is estimated at 65 to 85% of all reported TRALI cases. Of antibody with specificity known, those directed against HNA1A and HNA1B, HNA2A and HNA3A, and HLA-A2 are most frequently documented. Moreover, the presence of antibodies directed against HLA class 2 has been associated with the trial. An argument against immune model is that some patients who underwent the transfusion procedure did not develop TRALI despite the presence of leukocyte antigen. Some argument that can explain these issues are heterozygosity antigen receptor recognized by antibody. The clinical presentation of transfused patient may predispose to the greater or lesser manifestation of pulmonary transfusion reaction and lack of detection by clinician and lack of diagnosis of mild cases. Non-immune mediated TRALI can be attributed to the transfusion of biologically active compounds which are accumulated in the stored blood components such as bioactive lipid, pro-inflammatory cytokine, or platelet microparticle with high procoagulant activity. In non-immune mediated TRALI, no antibody were detected despite the clinical symptoms. The main inflammatory cells involved in the TRALI pathogenesis are polymorphonuclear neutrophils. For TRALI development, the production for the leukocyte antibodies is crucial. There is hypothesis of two-hit model postulated by the Silliman et al. In 1995, which assumed that TRALI onset depend on the coexistence of a factor that predispose to the recipient reaction as well as on the presence of leukocyte activating compound in the transfused blood. The first hit is mediated by the pro-inflammatory condition, and it is the aggression that activates the pulmonary endothelium and promotes the recruitment and adhesion of neutrophil to the capillary endothelium and later causes disarray of the lung alveolar capillary permeability barrier. The second hit is induced by the transfusion of blood component. These compounds induce neutrophil activation and release of cytotoxic factor that causes the endothelial damage and capillary injury. Reactive neutrophil secretes the pro-inflammatory mediators such as cytokine, that is interleukin 1, 6, 8, and TNF alpha, releases the proteolytic enzyme elastase and the azurosidine and produces the reactive oxygen species. These events initiate the cascade of immune reaction with the damage to vascular endothelium and produces the pulmonary capillary fluid leakage into alveolar space, thus causing edema. The neutrophilic airway inflammation of lung and the later disruption of lung alveolar capillary permeability barrier, it seems to be similar to what is seen in the other form of acute lung injury and ARDS, but with different origin. There is a common pathway in the pathophysiology of the TRALI, the damage to the alveolar capillary membrane, where neutrophil has been postulated as the protagonist cell for all reaction and subsequent trigger as described above. Antibody present in the transfused blood agglutinate to the first found neutrophil after transfusion, which are trapped in the microvasculature. It is well known that most leukocyte antibodies of IgG class produces active neutrophil agglutination rather than the passive. Neutrophil stimulates by leukocyte antibodies or biologically active lipid liberate the oxygen radical which damage endothelial cell of the lung capillary, leading to the increased vascular permeability and ultimately passage of the fluid and the protein into the alveoli. Now, this is the pathophysiological representation of the trally, which occurs because of the immune and the non-immune related. Immune related is mediated by the leukocyte antigen receptor plus the blood antibody donor, which results into the neutrophil activation and increase endothelial permeability. The non-immune related trally is occur because of the trauma sepsis, which results into the neutrophil activation, followed by the second hit, that is transfusion and the blood component, which results into the endothelial activation and cytokine release. So all this leads to the alveolar capillary pulmonary damage and results into acute respiratory failure. So acute respiratory failure is the main finding in the trial. Central clinical symptom is dyspnea and the co-occurs with the tachypnea, tachycardia, cyanosis, and pulmonary secretion. Another hemodynamic alteration like fever, hypertension are also reported. All these clinical characteristics are observed during transfusion or within 6 hours of transfusion in the absence of other factor that can develop acute lung injury, often during first hour of transfusion. During physical examination, the clinician can find decreased breath sound, diffuse crackles over lung field, and shallow breathing. The chest radiography shows the bilateral fluffy infiltration with no cardiomegaly, and with this, it can exclude the cardiogenic edema. Hemodynamic monitoring helps to differentiate trally and cardiogenic pulmonary edema. Normal or low pulmonary capillary wedge pressure and central venous pressure values are characteristic of the trally. Actually, hemodynamic monitoring has been needed to exclude other causes of trally because symptoms are similar to the other diseases, such as anaphylactic reaction, cardiogenic pulmonary edema, ARDS or bacterial infection, occasionally leukopenia, neutropenia, hypoalbuminemia, hypocomplementemia can be detected. The most prevalent symptom is transient leukopenia, which arises in 5% to 35% of patients. Now, the treatment of trally is the support of the lung function, and it goes not differ from the treatment of ALI and ARDS of any other etiology. Mild cases of ALI ARDS could be initiated with conventional measures such as oxygen therapy, and more serious cases require endotracheal intubation and mechanical ventilation strategies. The protective strategy should be applied in ALI and ARDS, which aim to prevent damage produced by mechanical lung ventilation. Sometimes the presence of hemodynamic impairment requires administration of the fluid. Aggressive administration is not recommended since, as in the ALI and ARDS of any etiology. It has recently confirmed that conservative strategy is accompanied by improvement in pulmonary function with decrease in duration of mechanical ventilation and ICU stay. Lack of response to fluid therapy may force the introduction of introducing an inotrope. The use of corticosteroid has been stated in some case report, but their use in trally is empirical and there is no evidence of their use. Thank you, guys.